You are listening to the Journal of Rheumatology's Editor's Picks with Dr. Earl Silverman, Editor-in-Chief.
Hello again, this is Earl Silverman, Editor-in-Chief of the Journal of Rheumatology. Welcome you to the November 2025 edition of Editor Summary. This month's featured interview is by our Associate Editor, Dr. Christine Peshkin, who interviewed Drs. Justin Smith and Stephanie Keeling about their paper entitled Identifying the State of Mental Health Care in Canadian Adults with Systemic Lupus Erythematosus.
So then what were the main barriers to mental health care access that you identified, and what were the interventions that were identified as most important by participants in the survey?
So I think the barriers that we identified were really no surprise to us. And we saw that it ranged from structural issues to systemic issues to more personal issues. So in terms of physicians, obviously it was things like time constraints, wait times for access to mental health care, and then also just lack of standardized referral systems. A lot of physicians just didn't know where they could send patients if they needed access quickly. And then in terms of patients, they also identified wait times as a major issue. But unlike what the physicians identified, patients actually noted issues with affordability, whether that was paying out of pocket or lack of insurance. And I think sometimes, we obviously deal with that with our medications, but we may not think about it in terms of other ways to access healthcare. And then interestingly, there were some, levels of discomfort discussing mental health care, both with the rheumatologist and with their primary care physician. And also just the word stigma was brought up, which interestingly, physicians did not think that stigma was an issue discussing these concerns with patients, but patients did still feel that there may be a stigma associated with this. In terms of the interventions, so we had a long list of interventions that patients and physicians could rate on a Likert scale for which they thought would be most useful. In terms of the interventions patients thought were more useful, mental health services actually integrated into the rheumatology clinic was number one, and then screening in the primary care physician office, and then followed that screening in the rheumatologist office. So they actually wanted direct mental health care available to them when they see their rheumatologist, which was interesting because on the flip side, the rheumatologists that we did survey, they did want access to referral systems or access to timely mental health care access. But the lowest rated intervention was actually standardized screening within the rheumatology clinic. So there is this disconnect that we identified between patient and physician. And I think that's very important going forward when we talk about potential next steps.
I hope you enjoyed listening to a part of Dr. Peshkin's interview with Dr. Smith and Keeling, and we'll listen to the full interview as well as read the manuscript and an accompanying editorial discussing the paper titled Improving Mental Health Care for People with Systemic Lupus Erythematosus, Time to Take Action by Drs. Rubenstein, Tumor, Blanco, and Knight. Both of these are available at our website at www.jroom.org, and the interview is also available on our YouTube channel. Now, moving on to the other articles in the November 2025 edition. In their paper titled Spondyloarthritis, Residual Disease Activity and Burden of Disease in Canadian Patients with Axial Spondyloarthritis, results from a multi-registry analysis, and the registry is the UNISON-Axial SPA registry, Choquette and co-authors address the knowledge gap in quantifying residual disease activity in Canadian patients with axial SPA. This is study of 980 patients from 3 Canadian databases from the provinces of Quebec, Alberta, Ontario, of patients with axial SPA, and they found that at 6 months, the percentage of patients who failed to achieve low disease activity, a BASDI of less than 3 range from 49.5% to a high of 65.8%. At 12 months, failure to achieve sustained low disease activity rose to 62% with a high of 81%. And pain persisted in nearly half of the patients. An accompanying editorial titled Ample Room for Improvement, Bitar and Diohar from Oregon Health and Science University, Portland, USA, highlight the need for early aggressive therapy, a better understanding of the role of non-inflammatory pain, and refining the outcome measures based on new biomarkers for inflammation in order to achieve the best possible outcome in patients with axial SPA. Serious infections are always a concern for patients on immunosuppressive therapy. Thorstad and co-authors in their paper titled Antimicrobial Use in Serious Infections Among Patients with Psoriatic Arthritis After Initiating Tumor Necrosis Factor Inhibitors, a nationwide max cohort study found that 399 patients after initiation of their TNF therapy received more antimicrobial prescriptions than matched general population controls with a hazard ratio of 2.26. In addition, after adjusting for covariance, PSA patients had a hazard ratio 1.43 for receiving a prescription for an antimicrobial following TNF inhibitor therapy as compared to the same patient before therapy. The risk was increased in the first year after initiation, but not in the second year, suggesting a transient effect. Contextual factors such as age, sex, BMI, and disease duration can significantly affect ultrasound findings in patients with PSA. In their paper titled Association of Contextual Factors with Sonographic Inflammatory and Structural Phenotypes in Patients with Psoriatic Arthritis, a cross-sectional study, Rubiero and co-authors in this cross-sectional study of 115 patients with active PSA found that age greater than 60 years was linked to significantly higher inflammatory and structural enthesitis, bone erosion scores, and the exposure to DMARDs correlated with significantly higher synovitis and tenosynovitis scores. The authors suggest that some of the observed findings could also reflect age-related changes such as osteoarthritis and degenerative enthesopathy rather than PSA-specific processes. Renal involvement is one of the most serious manifestations of SLE, but it is not clear whether age of onset of nephritis can alter the disease course. In their study titled Comparison of Lupus Nephritis Onset Before and After Age 50, Effect on Presentation and Outcomes in an Inception Cohort, Haruf and co-authors compared the outcome of 205 patients with lupus nephritis with an onset of before age 50 to 41 patients with age of onset greater than or equal to 50 years. They found that neither the short-term outcome of a complete proteinuria recovery at 1 year, nor the long-term outcome of a composite of end-stage renal disease, a sustained greater than 40% decline in estimated glomerular filtration rate, or death differed between the two groups. The next paper is by Lanzara and co-authors, is entitled Utilization of Rehabilitation Services After Idiopathic Inflammatory Myopathy Diagnosis, a U.S. retrospective cohort assessment. They found that of 22,443 patients with an inflammatory myopathy from the TriNext data set, 20.1%, 5.3%, and 3.7% had at least one PTOT and or speech language evaluation, respectively, over an average of 10 years follow-up. Of note, the mean time to rehabilitation services utilization was just under 2 years after the first coded diagnosis for inflammatory myopathy, suggesting that there were barriers to the use of rehabilitation services. Older age and prior use of the respective rehabilitation service was associated with a higher rehabilitation service use across all categories of inflammatory myopathy. Now, switching to pediatric rheumatology. First paper is by Kilbus and co-authors, titled Results of a Nationwide Multicenter Study in Childhood Sjogren's Disease. This was a nationwide multicenter study of 81 patients, 85.2% of whom were female, with a median age at symptom onset of 11.4 years and a median follow-up of 24.7 years. Common clinical manifestations included dry mouth, dry eyes, arthralgia, fatigue, and parotitis. Only 51 of the 81 patients met the 2016 ACR-EULAR classification criteria, while the remaining 30 were designated as the at-risk group. As a significant number of patients were designated an at-risk group for Sjogren's disease, the authors concluded that the current classification criteria for childhood Sjogren's disease may not be adequate, and that the pediatric-specific criteria may be needed. It has been estimated that successful transition from pediatric to adult care occurs in approximately 50% of pediatric rheumatology patients. Therefore, Eltal and co-authors, of which I am one, in their paper titled Evaluation of a Pediatric Adult Dyad Care Model for Transitioning Youth with Childhood-Onset Systemic Lupus Erythematosus, looked at the success rate of a pediatric patients who were transitioned and transferred to an adult clinic where both a pediatric and adult physician saw the patients together for a follow-up of 4 years in this combined clinic. 98.2% of the 164 patients who were transferred to the combined clinic had at least one visit within the first year of graduation. Median time, 3.5 months. 97.5% had greater than one visit at the clinic within the first year. And at the end of the study, 94.2% of patients were either still being followed in the combined clinic or had continued their adult care by the adult rheumatologists who attended this combined clinic. This latter group encompassed almost 50% of the patients who graduated. The next paper is by Flatman and co-authors and examines the use of anti-TNF agents in pregnant women and is titled Patterns of Use and Discontinuation of Tumor Necrosis Factor Inhibitors in Real-World Sample. They analyzed pregnancies that resulted in a live birth among women aged 15 to 45 with rheumatoid arthritis, ankylosing spondylitis, psoriatic arthritis, psoriasis, and or inflammatory bowel disease who were hospitalized for delivery over a 10-year period. Using market scan commercial claims base, they identified 3,711 pregnancies exposed to an anti-TNF inhibitor among 49,925 women in this database with one of the aforementioned diseases. Of these 3,711 pregnancies, 64% had continuous TNF inhibitor use throughout all 3 trimesters. 89% of the TNF-exposed pregnancies had preconception, and 68% continued TNF inhibitor therapy postpartum. The proportion of pregnancies with TNF inhibitor use throughout all 3 trimesters increased over time from 55% in the first time period to 73% in the most recent time period. In an accompanying editorial titled Confidence in the Use of Immunomodulatory Regulations During Pregnancy, How Can Patients and Clinicians' Experience Be Improved? Doctors Andrioli, Ulsgaard, and Schreiber from Denmark reviewed the history of the increasing use of TNF inhibitors during pregnancies and suggest that a treat-to-target philosophy can be maintained throughout pregnancies and may lead to the tapering and or discontinuation of corticosteroid usage. In the editorial, they present an excellent schematic illustration of the risk-benefit of treatment strategies as related to maternal and fetal pregnancy outcome. This month's Rheumatology Around the World is by Ribeiro and co-authors and is titled Toward Harmonized Recommendations for Psoriatic Arthritis, a comparative viewpoint on global guidelines, where they suggest that by combining global core recommendations with regional adaptations may lead to the optimal use of resources and improve clinical guideline sustainability and maintain local importance. Next, I would like to bring your attention to a systematic review by Junick and co-authors titled Multivariable Models to Predict a Diagnosis of Giant Cell Arteritis, Systematic Review and Meta-Analysis. This month's article for Panorama 360 Degrees of Rheumatology is titled Engaging Arab-Speaking Patients with Rheumatic Diseases Through Social Media, a Multinational Info-Epidemiology Analysis, and is by Hamuchi and co-authors. We have 2 images in rheumatology this month. The first is titled Multiple Hematoma, Purpura, and Ulcers in a Patient with Rheumatoid Arthritis, and it describes a 70-year-old female with RA who developed multiple areas of vasculitis following treatment with an IL-6 inhibitor. The second image is titled Crystalline Deposition in a Nose with a Sinus Tract, and it describes a 62-year-old who developed a firm mass on the tip of their nose and a sinus tract with a history of a white chalky discharge. The images show the sinus tract, and dual energy computed tomography reconstructions demonstrates monosodium deposition. Our research letter this month is titled Quantification of Hand Blood Flow by rubidium-27 positron emission tomography, and it reports that quantification of hand blood flow with rubidium-82 PET scanning is feasible and can effectively detect changes in response to reactive hyperemia in normal healthy controls, and suggests that following further validation, this technique may be used to monitor response to therapy for digital ulcers in patients with secondary Raynaud's phenomenon. We have 2 case reports. First is titled Recurrent Monoarthritis in a 40-year-old woman, and describes a 40-year-old woman with recurrent left wrist monoarthritis secondary to calcium pyrophosphate deposition. While the second is titled Cervical Lymphadenitis in a patient receiving tumor necrosis inhibitor therapy who had a mass below her mandible, which was resected, and PCR showed M. tuberculosis, and cultures after 60 days were positive for Mycobacterium haemophilum. I want to thank you for listening to this podcast and encourage you to read the complete articles in the November 2025 edition of the Journal of Rheumatology. These articles are available in either print or online edition of the journal, which is available at www.jrheum.org. And please watch the interview with the authors of the highlighted articles, and if you have missed any other articles from the past. They are available for viewing on our website and our YouTube channel. If you have any comments or questions of any of the articles in this month's edition of the Journal of Rheumatology, please send them to manuscripts@jrheum.com. And please join me next month for the December 2025 edition of Editor's Summary, and I want to thank you for listening.